There's a small plastic mask. Maybe you've had one pressed over your nose and mouth, getting your wisdom teeth out, a colonoscopy, some minor procedure you don't even remember scheduling weeks later. Someone tells you to count backward from 10. You get to 8, maybe 7, and then nothing. You wake up in a different room, and it's already over. That mask is one of the most quietly radical objects in American history. And for a long time, a really long time, it didn't exist. From 1776 to 1846, 70 years. That's how long the United States existed before anyone figured out a reliable way to make a surgical patient unconscious. Not before it was common, not before it was cheap, before it existed at all, anywhere in the country, in any form doctors trusted. If you needed a leg amputated in 1820, you were awake for it. Every second. So, what did doctors actually do when a patient started screaming halfway through an operation? Why did certain surgeons become famous? Genuinely, professionally famous, specifically for being fast, like speed itself was the treatment. And why did the man who finally solved this problem end up broke, bitter, and largely written out of his own breakthrough, while a dentist from Connecticut ended up dead by his own hand just a few years after trying? Here's what's coming. A surgeon who could take off a leg in under 2 minutes, and once, allegedly, took off more than the leg. A gas that got passed around at parties for laughs for almost 50 years before anyone thought to use it on an operating table. A public demonstration that went horribly wrong, in front of a crowd, in a hospital, with a man's reputation on the line. A dentist who tried to keep the solution secret so he could patent it and get rich off other people's pain. And a fight over credit that outlasted every man involved in discovering it. Because this isn't really a story about a chemical. It's a story about how something as basic as not suffering, something you assume, without thinking, every single time you go under today, had to be invented, fought over, nearly buried by pride and bad timing, and eventually, almost by accident, handed to the entire world in one afternoon in Boston. Before anesthesia, the most valuable skill a surgeon could have wasn't precision. It was speed. That sounds backwards. You'd think careful and slow would be the goal. But think about what surgery actually was in the early 1800s. No way to block pain, and no real understanding of infection either. A patient on the table was fully conscious, fully feeling everything, and going into shock the longer the operation dragged on. Shock could kill you just as fast as blood loss. So, the surgeon's job wasn't just to remove the diseased limb, it was to get in and out before the patient's body gave up on its own. This is where a Scottish surgeon named Robert Liston comes in. Liston worked in London in the 1830s and 40s, and he was, by every account, terrifyingly fast. His signature procedure was leg amputation, and he reportedly could take a leg off, through bone, in under 2 minutes. Some accounts say closer to 90 seconds. Some say he once did it in under 30. Picture what that actually required. No pause to steady your hand. No time to second guess. Liston would apparently keep the knife between his teeth while he worked, both hands free, cutting through muscle and sawing through bone, while an assistant restrained the patient and another controlled the blood vessels. Spectators would sometimes time him with a stopwatch. Not because it was ghoulish entertainment exactly, though it kind of was, but because speed was, genuinely, the closest thing to mercy that existed. And this is where the most famous story about Liston comes in, the one that gets repeated in almost every retelling of this era, even though historians are split on how much of it actually happened as told. The story goes that Liston was moving so fast during one amputation that he didn't just take the patient's leg. He also, in the same stroke, took off 2 fingers of his assistant, who was holding the leg steady, and, depending on which version you hear, either a spectator in the crowd was so shocked he died of a heart attack on the spot, or the assistant's wound got infected and he died days later, or both. Some versions call it surgery's only operation with a 300% mortality rate. The patient, the assistant, and the bystander. It's a great story. It's also probably not entirely true, or at least not verifiable in that exact form. But whether or not it happened exactly like that, the fact that people told it and kept telling it for over a century says something real. It tells you what people understood surgery to be in that era. A brutal, high-speed, high-stakes event where the surgeon's hands were basically a weapon against the clock, and where collateral damage, even to the surgeon's own team, was a real and accepted risk. Speed like Liston's could save you from an operation. It couldn't save you from feeling every part of it. And for certain surgeries, the slow, delicate kind, the kind that couldn't be rushed no matter how skilled the surgeon was, speed wasn't an option at all. Which meant, for those patients, there was nothing between them and the full experience of the knife, except whatever they'd been given to drink beforehand. Which is exactly the problem the next part of this story runs straight into. So if you couldn't be put to sleep, and your surgery couldn't be rushed like Liston's amputations, what did you actually get? What was on the table, literally, before the operation started? Mostly alcohol, whiskey, brandy, rum, whatever was on hand, and usually as much of it as the patient could physically drink beforehand. The idea was simple. Get someone drunk enough, and maybe the pain registers as distant instead of sharp. Maybe they black out entirely and don't remember it. In practice, it rarely worked that cleanly. People have wildly different tolerances, and a patient who was already frightened, already in poor health, already possibly losing blood, didn't process alcohol the way a healthy person at a bar would. Too little did nothing. Too much. And you risked the patient going into deeper shock, or choking, or simply dying from the alcohol on top of everything else the body was already struggling with. Opium and its derivatives were the other option. Laudanum specifically, which was opium dissolved in alcohol, so in a lot of cases patients were getting hit with both at once. Laudanum was common enough that it wasn't just a surgical tool, it was sold over the counter for everything from teething babies to menstrual cramps. But like the whiskey, dosing it before surgery was guesswork. Doctors didn't have a reliable sense of how much was enough to dull sensation without also dulling breathing, heart rate, the basic things keeping a person alive during an already dangerous procedure. And then there was the part that had nothing to do with chemistry at all. Physical restraint. Hospitals employed men sometimes called dressers, assistants whose actual job, alongside handing over instruments, was to hold the patient down. Not gently. Firmly, sometimes with straps, sometimes with sheer body weight, because a patient in agony will thrash, will try to get away from the knife, and a moving patient during an operation was dangerous for everyone involved. There's a persistent image from this era of patients biting down on a piece of leather or wood during surgery, something to clamp their jaw around besides their own tongue. Whether or not that specific detail is accurate in every case, the broader picture is surgery meant being physically overpowered by other people so that the surgeon could work. None of this reliably solved the actual problem. Patients often remembered every second of an operation in vivid, specific detail. Accounts from the era describe people recalling the exact sound of a saw against bone, the exact sensation of a scalpel, years afterward. Whiskey didn't erase the memory so much as blur the edges of it sometimes. Laudanum was a gamble every time. and the solution of just holding someone down didn't address the pain at all. It just made sure the pain didn't stop the surgery from finishing. Here's the strange part, though. The part that makes this whole era feel less like a story about missing technology and more like a story about missing imagination. The actual chemical that eventually solved this problem had been sitting around, publicly known, for decades already. It wasn't buried in some lab. It wasn't waiting to be discovered. People had been using it, recreationally, for fun, at parties, in front of paying audiences, since before the turn of the century. Nobody had thought to bring it into the operating room. Go back further than 1846. Go back even further than Liston's amputations. Go all the way to the late 1790s in England to a young chemist named Humphrey Davy. Davy was experimenting with a gas called nitrous oxide, what we now call laughing gas, and in the course of testing it on himself and others, he noticed something specific. It didn't just make people giggle and act strange, it seemed to dull physical pain. Davy had a toothache at one point during his experiments, tried the gas, and noted that the pain seemed to fade. He apparently even wrote, in his own notes, that nitrous oxide might be useful during surgical operations. And then, essentially, nothing happened with that idea. For decades. What happened instead is that nitrous oxide became entertainment. Laughing gas parties became a real, popular phenomenon on both sides of the Atlantic. You'd pay admission, inhale the gas in front of a crowd, and stumble around giggling, stumbling, occasionally injuring yourself without seeming to notice, while an audience watched and laughed. It was treated the same way we might treat a novelty sideshow act today. Traveling performers would set up demonstrations in town halls, charge a fee, and invite volunteers up from the crowd to inhale the gas and provide the entertainment. People got hurt during these shows sometimes, fell off the stage, ran into furniture, and audiences noticed something curious. The people under the gas didn't seem to feel it. That detail sat there, in plain public view, for close to 50 years. Not hidden, not a secret held by a handful of researchers. Watched, repeatedly, by ordinary audiences in ordinary towns, who saw people get hurt without registering pain and thought, that's funny, not, that's useful. Which brings in a Hartford, Connecticut dentist named Horace Wells. In December of 1844, Wells attended one of these traveling laughing gas shows, and he saw something the rest of the crowd didn't quite register the same way. One of the volunteers, a man named Samuel Cooley, inhaled the gas, stumbled around the stage, and gashed his leg badly enough to bleed, visibly, obviously, and showed no reaction to it at all. No wince, no yelp, nothing. Afterward, Cooley told Wells he hadn't felt it happen. Wells was a dentist. He spent his professional life causing people pain, pulling teeth, with nothing to offer his patients except, at best, a shot of whiskey beforehand. And here, in a rented hall, in front of a paying audience, was a substance that appeared to make a man immune to a bleeding leg wound. He didn't see a party trick. He saw a tooth extraction. The very next day, Wells arranged to have nitrous oxide administered to himself, while a colleague pulled one of his own teeth. It worked. He felt, by his own account, almost nothing. For the first time in this story, someone had actually connected the party gas to the operating chair. Wells was convinced he'd found the answer to a problem that had existed for as long as surgery itself. He wanted to prove it, not quietly, not just to a few colleagues, but publicly, in front of the people whose approval would matter most, the doctors at one of the most respected hospitals in the country. It should have been the moment this whole story ends early, decades before it eventually did. Instead, it became one of the most painful public failures in the history of American medicine. Horace Wells got his chance in January of 1845 at Massachusetts General Hospital in Boston. one of the most respected medical institutions in the country. He'd been invited, through a former dental partner named William Morton, to demonstrate nitrous oxide in front of a room full of doctors and medical students. This wasn't a small audience of curious colleagues. This was the establishment, the people whose respect could make his discovery real, or whose dismissal could bury it. The patient was a medical student who'd volunteered to have a tooth pulled under the gas. Wells administered the nitrous oxide, the crowd watched, and the extraction began. And the patient cried out. It wasn't clear, even in the moment, exactly what that cry meant. Some accounts from the room suggested the patient may have felt little or nothing, and the sound was more reflexive than a genuine pain response. The gas may have been withdrawn too early, or the dose may have been slightly off, but none of that mattered in the room that day. What mattered was what the audience saw and heard. A man in a chair, having a tooth pulled, making a sound that looked exactly like pain. The crowd reacted immediately, and not kindly. Several onlookers reportedly shouted, "Humbug!" the era's word for fraud, a scam, a con. Wells was mocked, openly, in front of the exact audience he'd needed to convince. He left Massachusetts General that day, having accomplished the opposite of what he came for. Instead of proving nitrous oxide could solve the oldest problem in surgery, he'd made himself look like someone who'd wasted the time of serious doctors with a party gas and false promises. It's worth sitting with how brutal that must have been. Wells wasn't a con man. He believed, correctly, that he'd found something real. He'd tested it on himself first, felt it work, and staked his professional reputation on sharing it. And in the span of a few minutes, in front of the room that mattered most, it fell apart in the worst possible way. Publicly, loudly, with his name attached to the failure. He went back to Hartford. His dental practice struggled. The humiliation in Boston followed him, the way public failures tend to, and nitrous oxide, the substance he'd correctly identified as a genuine breakthrough, went back to being what it had been for the previous 50 years, a party novelty, not a medical tool. Here's the part that makes this chapter sting even more in hindsight. Wells wasn't wrong. He'd correctly made the leap nobody else had made in half a century, connecting a recreational gas to real surgical pain relief. His instinct was sound. His timing, his dosage, or simply bad luck in that one specific demonstration cost him everything. Being right wasn't enough. He needed the room to see him be right, and instead, the room saw him fail. Failure in front of an audience doesn't just cost you that one moment. It changes what happens next, for you, and for the idea itself. Because Wells's public collapse didn't kill the concept of surgical anesthesia. Someone else was going to make that connection eventually. The underlying idea was too obviously correct to disappear entirely. But it meant that when the next person tried, it wasn't going to be Wells reclaiming his moment. It was going to be somebody else, watching from a slight distance, who'd seen exactly what went wrong and had every incentive to avoid repeating it. That person was William Morton, the same colleague who'd helped set up Wells's disastrous demonstration in the first place. William Morton had watched Wells fail up close. He'd helped arrange the demonstration, he'd seen the crowd turn, and he'd seen exactly what public humiliation looked like when a new medical idea didn't land clean. Whatever Morton took away from that day, one thing seems clear from what happened next. He wasn't going to walk into a room unprepared the way Wells had. Morton was a dentist too, based in Boston. And like Wells, he understood the problem from the inside. Pulling teeth without any way to control pain wasn't just unpleasant for patients. It was bad for business. People avoided the dentist as long as they possibly could, which meant showing up with worse problems than if they'd come in early. A reliable way to eliminate pain during a procedure wasn't just a medical breakthrough waiting to happen. It was, quite plainly, also a business opportunity. Instead of nitrous oxide, Morton turned his attention to sulfuric ether. Ether had a reputation similar to laughing gas. It was used recreationally at so-called ether frolics, where people would inhale it for the intoxicating, dizzying effect, sometimes at parties not unlike the nitrous oxide shows. It had also been used in a few earlier low-profile instances by doctors like Crawford Long, a physician in rural Georgia who'd actually used ether during a minor surgery back in 1842, years before any of this. But Long hadn't published his results, or made any real effort to bring it to wider medical attention. He'd essentially discovered the answer years early and let it sit, unannounced, in a small-town practice. Whatever the reason, caution, isolation from the major medical centers, simple lack of urgency, it meant Long's early success wouldn't matter to the story that was about to unfold in Boston. Morton began experimenting with ether in secret. He tested it on animals. He tested it on himself, inhaling it alone in his office to gauge the dose and the effect, at real personal risk. Ether in the wrong amount could kill you just as easily as it could knock you unconscious safely. He built his own inhaling apparatus, a glass device designed to let a patient breathe ether vapor in a controlled way rather than just soaking a rag and hoping for the best. And critically, unlike Wells, Morton didn't rush to a public demonstration the moment he had promising results. He refined his method. He practiced. He tried to understand dosage and timing well enough that he wouldn't be standing in a crowded operating theater watching a patient cry out. He also did something Wells never did. He tried to keep the formula secret. Morton disguised the smell of his ether with aromatic oils and marketed it under a different name, Lithion, with the clear intention of patenting it once he'd proven it worked. This is worth sitting with for a second, because it's a genuinely uncomfortable piece of the story. Morton was working toward a method that could eliminate one of the oldest forms of human suffering. And part of his plan involved trying to control who got to profit from it. If it worked, and he could patent it, doctors and hospitals across the country would potentially owe him money to use it. It's the kind of tension that shows up again and again in the history of medical breakthroughs. The line between genuinely wanting to solve a problem and wanting to own the solution isn't always clean, and Morton sat right on top of that line. Whatever mix of motives he was working from, by the fall of 1846, he believed he had something that worked reliably. And he wanted the same thing Wells had wanted the year before: a public demonstration in front of the most respected doctors in Boston to prove it beyond doubt. This time, the setting was Massachusetts General Hospital again. The same institution. Almost the same stakes. A room that had already watched one dentist fail spectacularly with exactly this kind of claim. Morton was about to find out if he'd get a different result. October 16, 1846. Massachusetts General Hospital, Boston. The same hospital where Horace Wells had been laughed out of the room 20 months earlier. The operating theater there was known, appropriately enough, as the Ether Dome, a domed amphitheater-style room with tiered seating so students and doctors could look down and observe surgeries in progress. The surgeon that day was John Collins Warren, one of the most senior and respected surgeons in the country, a man whose approval carried enormous weight. The patient was a young man named Edward Gilbert Abbott, who had a vascular tumor on the left side of his neck that needed to be removed. And in the room, watching from the tiered seats, was exactly the kind of audience that had turned on Wells. Skeptical doctors, some of whom had likely been present for that earlier failure, or at least heard about it in exhaustive detail. Morton arrived late. Reports differ on why. Some say he was finishing adjustments to his inhaling apparatus. Warren, waiting, is said to have remarked to the room that perhaps Morton wasn't coming at all, a comment that would have landed as a pointed echo of the Wells fiasco. Then Morton arrived, apologized for the delay, and got to work. He administered the ether through his glass inhaler to Abbott. After a few minutes, Abbott appeared to lose consciousness. Morton turned to Warren and said the room was his. Warren began the operation, cutting into Abbott's neck to remove the tumor, while the room watched in near total silence, almost certainly braced for the same outcome as before. A cry, a wince, some sign that this was, once again, going to fail in front of everyone who mattered. It didn't happen. Abbott lay still. He didn't cry out, didn't flinch, didn't respond to the incision at all. When the operation was finished and Abbott regained full awareness, he reportedly said he'd felt nothing. Some accounts describe him saying it felt like his neck had been scratched. Nothing more. Warren turned to the assembled crowd, and according to the version of this story that's been repeated for well over a century, he said, "Gentlemen, this is no humbug." Whether Warren said those exact words or something close to them, the meaning was unmistakable to everyone in that room. The same word that had been hurled at Wells as an insult, humbug, fraud, con, was now being used to explicitly deny that this was one. It's hard to imagine a more pointed way for that moment to land, whether Warren chose the word deliberately or not. News of what happened in the ether dome spread almost immediately and almost impossibly fast for 1846. Within weeks, doctors in other American cities were experimenting with ether. Within months, it had crossed the Atlantic. Surgeons in London were using it by December of that same year. For a medical breakthrough in an era without telephones, without any kind of instant communication, the speed of adoption tells you something about how badly this problem had been waiting to be solved. Doctors everywhere had been living with the same 70-year gap Wells and Morton had been living with. The moment a demonstrated, credible solution existed, almost nobody hesitated. For one afternoon, it looked like a clean, satisfying ending. A problem that had defined the entire history of surgery, solved, publicly, decisively, in front of the exact skeptical audience that needed convincing. But almost as fast as the news spread, so did something else. A much less dignified fight over who actually deserved the credit, and more specifically, who deserved to get paid for it. Morton had come into that operating theater with a patent in mind, not just a discovery. And within weeks of his triumph, that decision was going to turn what should have been the happy ending of this story into one of the ugliest, longest-running disputes in the history of American medicine. Almost immediately after the ether dome demonstration, the fight started. And it wasn't really a fight about science. It was a fight about money and credit. Who got to be known as the man who ended surgical pain, and who got to profit from it? Morton moved fast. He tried to patent his ether formula under the name Lithion, disguising its actual composition with added oils so other doctors couldn't simply replicate it themselves without going through him. This created an immediate problem, because Lithion was just ether with cosmetic dressing, and any competent chemist could figure that out fairly quickly. Doctors who'd witnessed the demonstration and wanted to start using it in their own hospitals were now being asked to pay licensing fees for a substance that was, chemically, already well known and widely available. That didn't sit well with a medical community that had just watched this thing solve a problem for all of humanity, not just for Morton's bank account. Then Horace Wells re-entered the story, not as the man vindicated for having gotten there first with nitrous oxide, but as someone watching Morton receive credit, publicity, and potential wealth for what Wells felt was fundamentally his idea, just with a different gas. Wells had been the one to make the original leap connecting a party gas to surgical pain relief. He'd tested it on himself. He'd tried to prove it publicly, nearly 2 years before Morton's success. And now Morton, someone Wells had personally helped set up his own disastrous 1845 demonstration, was being celebrated as the man who solved anesthesia. Wells spent the years after 1846 trying to reclaim some piece of the credit and increasingly struggling, both financially and personally. He experimented further with other inhaled substances, including chloroform, in ways that seemed to have affected his physical and mental health. In January of 1848, in New York, Wells died by suicide. He was in his early 30s. Some later medical historians have argued that Wells deserved significantly more credit for the underlying discovery than he received during his lifetime, that his original insight was sound, and that the difference between his failure and Morton's success came down largely to a bad batch of gas, poor timing, or simple misfortune in one specific demonstration rather than being wrong about the science itself. Then there was Crawford Long, the Georgia physician who had quietly used ether in a minor surgery back in 1842, 4 years before Morton's public demonstration, but never published his results or pursued recognition at the time. Once Morton's fame made ether anesthesia a national story, Long came forward with his own earlier case, arguing he deserved priority credit for being first, even though he'd never told anyone at the time it happened. The dispute dragged on for years. It reached Congress at one point, with petitions asking the federal government to formally recognize and financially compensate whoever the true discoverer of anesthesia actually was. Verify the extent and outcome of congressional involvement. No clean resolution ever really emerged. Morton spent much of the rest of his life pursuing recognition and compensation he felt he was owed, spending money he didn't have on the effort, and by most accounts died in 1868, in significant debt, still fighting for a decision that never fully came. So the men who'd actually solved one of the oldest problems in the history of medicine ended up, almost to a person, poorer, sicker, or dead earlier than they should have been, fighting each other over a discovery that was already spreading across the world without any of them. While Morton, Wells, and Long were tearing each other apart over credit, ether anesthesia itself didn't wait around for the dispute to resolve. It just spread. Within a year of the ether dome demonstration, hospitals across the United States had adopted it as standard practice for major surgery. Chloroform arrived shortly after as an alternative, discovered to have similar anesthetic properties, and preferred by some doctors because it worked faster and required less equipment than Morton's ether inhaler, even though it carried its own risks, including a higher chance of affecting the heart. Within a decade, the idea of operating on a fully conscious patient, the standard for the entire history of surgery up to that point, had become almost unthinkable in any hospital with access to either substance. And this changed what surgery actually was, not just how it felt. When a patient no longer needed to be rushed through an operation before shock or unbearable pain set in, surgeons could suddenly slow down. Robert Liston's 90-second amputations had been a triumph of speed under horrific conditions. But speed had also meant surgeons avoided anything that required real precision. Anything inside the abdomen, anything near major organs, anything that simply couldn't be done in under 2 minutes, no matter how skilled you were. Anesthesia didn't just remove pain. It removed the time pressure that had been quietly limiting what surgery was even capable of attempting. Procedures that would have been essentially impossible to perform on a conscious, thrashing patient became, for the first time, realistic. So this looks like the ending. Pain solved in one afternoon, in one room in Boston. And in the most immediate sense, it was patients undergoing surgery after 1846 were no longer expected to simply endure it. That part of the story really is a clean, genuine triumph, whatever mess of ego and money surrounded the men who got there. But here's the twist that keeps this from being a fully happy ending, and it's worth sitting with for a second. Anesthesia solved pain. It did not solve the thing that was actually killing most surgical patients. That thing was infection. Surgeons in 1846, and for decades afterward, still had no real understanding of germs. They operated in the same clothes they'd worn all day, used instruments that had been used on other patients without any real sterilization, and worked in rooms that weren't remotely sterile by any modern standard. A patient could survive an amputation completely pain-free thanks to ether, and still die days later from an infection that nobody in the room understood how to prevent. It would take almost another 20 years until the work of Joseph Lister in the 1860s, who pioneered antiseptic technique using carbolic acid to clean wounds and instruments. Before that second, much larger killer really started to be addressed. So the 70-year gap this story opened with, the one where nobody could make surgery painless, was actually just one layer of a much bigger problem. Solving it in 1846 was genuinely enormous. It changed what surgeons were willing to attempt, and it changed what patients had to endure. But it didn't make surgery safe. It made surgery survivable in a new, specific way, while a second invisible killer kept operating in the background for another generation, essentially unnoticed by the same rooms celebrating their victory over pain. That's usually how this works, in medicine and elsewhere. You solve the problem you can see and feel. The one you can't see yet keeps going, quietly, until somebody else spends another couple of decades figuring out how to name it. So what does this actually add up to? It's not really a story about ether or nitrous oxide or any single chemical. It's a story about how the things we now assume are basic decency, not suffering, not being held down by strangers while someone cuts into you, had to be fought for. Invented first, then demonstrated publicly in front of skeptical rooms that laughed one man out the door and only grudgingly accepted the next. Then fought over, bitterly, by the very people who'd made it possible because being the one who solves human suffering turned out to also mean being the one who gets to own it, patent it, profit from it. Comfort, it turns out, is almost never given. It's extracted, slowly, expensively, usually by people who don't end up benefiting from it themselves. And that pattern didn't end in 1846. Right now, in hospitals across the country, tens of millions of Americans go under general anesthesia every single year for routine, unremarkable procedures, wisdom teeth, colonoscopies, minor surgeries scheduled on a random Tuesday, without a second thought about what they're being given or why it works. It's completely invisible now, which is exactly the point. The thing that got Horace Wells laughed out of a hospital, that got him branded a fraud in front of the room that mattered most, is now so unremarkable that most people couldn't tell you the name of a single person who made it possible. That's usually the final stage of any real breakthrough. It stops being a story. It just becomes the thing you assume was always there. That's the story of how America actually works. Subscribe for the next one.